So this is just a sudden webinar, okay, that came out of the blue. I wasn't really planning for it, but I found that I had some extra free time, so I thought of doing something useful with my life. So I'm going to talk about tips on communication for the MRCOG Part 3 exam. It's going to be something general, not specific, but I would be giving essential tips that I would really appreciate that you listen to them, digest them, and apply them while you're practicing and preparing for the exam, so you can actually apply them during the exam. Why is communication important? I think it's for overseas, this is the domain out of all of the 5 domains. It's the one that you really need to focus on during preparation. For example, knowledge, safety, colleagues, these are things that you can memorize. But communication is something that you need to have as a habit. Understand it, practice it, repeat it. At the beginning, you can find yourself, you're writing it down, the sentences that you need to use. That's absolutely fine. With time, even while you're practicing, read it from your notes. For my students during the classes, I tell them, when I see they're struggling a little bit with communication, I tell them it's absolutely fine. When you prepare your case scenario and we come and do it with me in the class, have a draft written down. So at least when you are practicing and performing cases, you're doing it in the right way. And the more you do it, or the many times you do it correctly, you will not forget doing it at all. Okay? So communication is important because in the exam, we have 14 scenarios. One of them is teaching, so we'll take that out. 9 of them, you'll be communicating directly with the patient. And 4 of them, you would be communicating directly with the examiner. So let's come and see, when you're communicating directly with the patient, you need to have some skills. And the exam, it's actually simple. They don't want a very complicated aspect of communication, just very simple and plain, because it assesses your communication with patients in a day-to-day basis. Every clinical situation in the clinic, in the ward, labor ward, gynae ward, in theatre, they just want to see how you would communicate with patients under these circumstances. So in order to communicate really well, there are a few things that are essential and you need to do. Number 1, you need to read the scenario carefully. In the 2 minutes before starting your case, read the scenario carefully, but don't be very slow, and then decide the important issues you are going to address. And also decide what you should stress for the patient to take home. What do you want the patient to understand from the consultation? Also, in the 2 minutes, make sure you write down the important points you want to discuss. Otherwise, if you don't do that, you may have already figured it out in the 2 minutes, but then you may forget them once you sit in front of the patient and you have her in front of the screen. I'm saying screen because the exam has been going on since January and March, beginning of March, digital. And this time is going to be digital and hybrid for some centers. So you won't have a pen and paper like the old way of the exam. You're going to have a digital note. So the program is designed in a way that you have a place where you can type your notes in the 2 minutes on the screen. The examiner will not see the notes because you can choose to hide your notes. Anyhow, they don't care about what you write in the 2 minutes. But for you, okay, for your sake, if you want to pass the exam, please type something down in the 2 minutes, even if it's a sketch. Point number 2 is introduce yourself to every patient that you see and confirm the identity of the patient as per given scenario. Okay. Number 3 is that you should check the patient's prior understanding, about her illness. So what do I mean by that sentence is that you want to know what she knows so far. okay, about what she has. Because usually patients are referred by GPs or by midwives. Rarely they walk in directly to the hospital unless it's an emergency. So she will tell you about what she discussed with the GP and how far she knows in terms of her problem. How would this help you? It's going to help you formulate as from where you want to start your consultation and how much information you need to deliver to the patient. In addition to that, it will also help to know the concerns that the patient might be having. So you can see from the beginning, one simple question can really help you a lot as well in saving time. Because let's say she has she's epileptic, okay, and she's pregnant. She went to her GP um, to do a pregnancy test. GP said so. Usually, it's not necessary for them to be referred by the midwife, even if they're pregnant. GPs can do that. So the GP referred her to the hospital. So she may have discussed something with the GP, or she may have read leaflets or browsed through the internet about epilepsy in pregnancy. So when you ask her that question, she will tell you what she knows so far, and she will tell you what she's worried about. So you wouldn't need to repeat the information that she told you. If she knows that in epilepsy, the medication can cause this and this and this, or if she knows that for her health, her fits may get worse or better, you can just, when you come to the consultation, start it. You will tell her that what you said is correct, and then you can add upon to it. You won't need to repeat from the beginning. So I do think that point is really, really, really important. And I would stress upon it, for example, in another important scenario, let's say the patient had primary amenorrhea, went to the GP. So GP usually assesses it and orders for investigations. And then when the result is out, they send the patient to the hospital. So you have the history in front of you, the examination done by the GP, you have the test results, karyotyping and ultrasound scan. It shows androgen sensitivity syndrome. If you start your counseling by telling her that, Amy, well, I understand from your GP letter that you didn't have your periods yet. You're 18 years old right now. He asked you a couple of questions. You're medically fit and well. You didn't have any surgeries. You didn't have any radiotherapy or chemotherapy before. Family history is okay. He examined you and you had this, this, and this. You, from the beginning of the scenario, you are talking too much. Okay, you're taking lots of time. The examiner wouldn't be impressed about that. However, if you do it the other way around, tell her, hello, Emily. Is it okay if I call you Emily? She'll tell you yes. So, Emily, I have a lengthy letter from your GP and understand that you have gone through a series of tests and they ask you questions as well. So, can you share with me basically what you understand about what's going on with you up until now? She will tell you, Emily now will explain to me what has been going on and what she knows. Okay, the GP may have told her, well, I am thinking about a possibility of androgen sensitivity syndrome. So that would help you in breaking the bad news. At least she has an idea that it's a possibility, not like another young girl who has no idea that there's something called androgen sensitivity syndrome that exists. Point number 4, look fluent. And for you to be fluent and not pause in between, not hesitate while you're communicating with the patient, is for you to practice a lot. Okay, watch videos. Strategy videos are very, very nice. You can watch them, and just when you're watching them, don't try to memorize, just try to see how the actors and the candidates are communicating. You also need to look professional. Okay, and professional, it's well, apart from dressing up nicely, you want to look professional and confident. And the most important rule is to avoid medical jargon. No medical jargon at all. Because if you mention medical jargon, the patient wouldn't understand what you're saying. If she doesn't understand what you're saying, she won't be able to make an informed choice about, okay, do I agree for the following treatment or do I not? The result of that can affect your marks in safety. It can affect your marks in communicating with the patient. Ask open-ended questions, please, and that would be in the history. So the more you let the patient talk, the more marks you would get. And you try to do that from the very beginning, okay, even before the history. Try just to find one open-ended question at the beginning after greeting the patient that will let her give you a sentence, not a yes or no answers. For open-ended questions, I have a video on the Facebook group about information gathering, history taking. You can just go and watch that, okay? Also, listen attentively. And today I am going to, just let me change the pen color. Today I am going to focus on this point specifically, but just let's finish from the rest and then we'll come back to that. React to patient's cues. For example, if the patient looks stressed out on something, okay, maybe you said something about a side effect or a risk from a surgery that you're offering her as an option, and she looks stressed. You can see it on her face. Please don't ignore it. Pause for a moment and then tell her, I can see that you got a little bit stressed out or worried from what I mentioned about the procedure. Can you share that with me? You want to see why she's worried. Is she afraid from a certain risk that you mentioned? So you can reassure her. And when patients are anxious during the exam, or they're sad, they're stressed out, or even they're not paying attention, or they're in a hurry, they are giving you cues. They are instructed to act that way. That's why you have to learn how to respond to them. Sometimes I do understand that candidates would pick it up, but then they wouldn't know how to go about it. What should I say to the patient? So therefore they choose to ignore it and not address it. And a bulk of your marks can go missing because there can be something hidden that you just need to address, and it has lots of marks in it. Some patients may even cry, and of course now it is digital. You wouldn't like hand her a tissue, but sometimes in some exams the examiner would place a box of tissues on the table so you can use it. They want to see, would you use that tissue or not? This is how important it is to react to patients' cues. Point number 8 is that empathy is a very important skill of a doctor, and you need to really master empathy and sympathy, especially when you're breaking bad news. Okay, I'm not going to go in depth about it here because this session is not about empathy and sympathy. If you want to know more about it, go on my YouTube channel, MRCOG Part 3 Circle. We've done case scenarios on ectopic pregnancy and I think IUFD, okay, a couple. Negotiate with the patient and select an appropriate management plan. And to select an appropriate management plan, you need to know your guidelines. So knowledge would play an important role in this point. And what I mean by negotiating is another important communication skills of a doctor. The patient asks you for something, you can't tell her, no, I'm sorry, you can't have that. Inquire more, dig behind it. Why doesn't she want the option? What she's concerned about? What are her worries? What are her views or even thoughts about this? Okay, the option that she's asking that is usually against medical advice, or she may be refusing something that you're offering her. And of course, if she's not lacking mental capacity, then of course you would know that from the beginning. You would then negotiate with her to see what's the rationale behind her refusal, and then try to address it and see if you can, convince her at least, or if she doesn't get convinced, at least to give it a thought and not rush into saying no for this treatment. If there's a case scenario in the exam on negotiation skills, you would be marked on your negotiation skills purely. Okay, they would be, the bulk of the marks would be there. If you don't negotiate really well, then you can fail communication on that case. At the end, make sure that you summarize whenever you have time and confirm in between while you're explaining, and even at the end after you finish, that the patient has understood what you have told her. Some useful sentences, okay, that will help fill in the gaps while you're having a conversation with the patient. Also, it will shape your communication with the patient into a smoother and a realistic one. You don't want to sound that you're just telling her, okay, this is your management plan, these are your options, and you explain everything in layman terminology, and that's it. You want to be able to, be a normal human being and communicate with the patient out and say sentences that are not related to the medical problem or the issue that she has. These are the generally commonly needed sentences you can use, but you can use your own sentences if you've already been practicing. Okay. Someone asked me here, Ayman, how are you? So she asked, will we use our surname or first name is okay? All right, so it would depend upon what the patient chooses to be called. Right, what I would prefer is that when you go to this point here, that hi, I'm Dr. I will mention usually at the beginning my first name. Okay, we'll say hi, I'm Dr. Wafa, I'm one of the doctors here. May I confirm your name and age, please? And what would you like to be called? Let's say her name is Amy Smith. Okay, and she tells me, call me Amy. I will tell her, please call me Wafa. So she wanted me to call her by her first name, Amy. So I mirrored that, okay, and I told her, okay, please call me Wafa. If she tells me, call me Miss Smith, so she wants it to be a little bit more formal. So she says, call me Miss Smith. I'll mirror her as well, make it formal and tell her, so remember, my name is Wafa Hamad. I'll tell her, please call me Dr. Hamad. So I'm mentioning doctor. She said Miss, and then her surname, I'll say doctor and my surname. But okay, so Ayman, I understood your question now. You mean at the beginning when you say, hello, I'm Doctor, use your first name. All right, there's not much difference, to be honest, actually, whether you say, hi, I'm Dr. I'm Dr. Hamad, one of the doctors here, or I'm Dr. Wafa. It doesn't really matter. All right. Okay, so another sentence that you can use to confirm why she's here. So if you know, so if the patient, well, I don't really want to confuse all those who are new, because there's lots of many ways according to the scenario that you have in front of you. So I just want to make it as simple as possible. So if the patient is referred to you with a complaint, then you don't really need to make it an open-ended question. You can just confirm and tell her, so I have a letter from the GP stating that you have been complaining of painful periods. Am I right? Or you can, if she has gone to her GP and she requested to see you, and that would be written in the letter that this patient has requested to be referred to the hospital because she wants to what can I say? She wants to have tubal ligation. Okay, so here she requested to see you. Then you can use this one. I understand you wanted to see me to discuss about this, this, and this. Or another example is that if the patient is in the ward and she asked for a doctor, and you go in to see her, and that will be mentioned as well, specifying the scenario. You can tell her, I understand you wanted to see me to discuss about this. Or you can tell her, I understand you want to see me. How can I help you? Right. Another way you want to confirm the aim of the consultation in the clinic, you can ask the patient, how can I help you today? I think that's very plain and simple. So use that. At the beginning, when you're starting practice, you'll find yourself using one way only, but then write down multiple ways and right next to it the exact situation will be, and then you will find yourself that you're changing a little bit to make it just very suitable for the scenario. But at the end, if you just use how can I help you today, that will be enough, right? And another thing is that when you want to confirm that these results belong to the patient, some people find it a little difficult to formulate that sentence. So a simple way, may I confirm your ID details with you before we discuss the results? She will tell you less. Yes, or you can tell her that, well, Amy, after confirming that these results belong to you according to your ID, it shows that, then you continue. So that's another way of communicating and telling her that bit of information. Also, another sentence you can use, let's say the patient, you can use this one if you have an angry mother who came in, you either prescribed for her daughter contraceptives or she underwent a termination of the pregnancy with you in the hospital. How can you do this to my daughter without telling me? I'm very angry at all of you. How can you do that? She's just a little baby girl. And then you tell her that I can see, Ms. Smith, that you are actually frustrated and angry at the moment. If I were in your shoes, I most probably would do the same. That's another sentence that you can use to communicate, because if you don't know how to respond to that, you can just go silent and tell her okay. So that's another sentence. Also, if you're giving bad news and the patient's like shocked, she'll tell you, well, I didn't really expect this. How can this be happening to me? Tell her, it's understandable that, or I understand this isn't what you wanted to hear. I wish the news was better. Don't ignore what she mentioned. She mentioned out loud to you that she can't believe what she has been hearing. She can't believe that you're telling her she has this problem or that she has lost her baby. You want to respond to that instead of ignoring her and telling her, I'm sorry. Show her that, yes, you know that she didn't want to hear such news. She wasn't expecting it. If the patient, for another example as well, if the patient is concerned about something, okay, she will tell you, well, let's say usually those who express concerns are pregnant women, her baby they want to take care of. Let's say she has a medical problem and she told you, well, I'm really concerned. I just found out that I'm pregnant at the moment and I'm taking carbamazepine. Is it going to affect my baby? I didn't really know that I was pregnant until now. Well, I can see that you're quite worried and your concern is really understandable. But let me assure you, carbamazepine is not really harmful for the baby. And then you continue. So here, I didn't go and talk to her about the effects of the carbamazepine right away. I showed her that I understand, I can see, I can see and understand why you are concerned and worried that much. If the patient asks you a question and you don't know the answer at all, don't try to lie or go silent. Both ways are not good. Be honest and tell her that you don't know, okay? It's good practice at the end. It's part of safety as well. There's nothing wrong with saying, I'm sorry, I'm unable to answer your question now, but I'll find out and get back to you. Or another way, you can tell her that this question is rather difficult for me to answer at the moment. Please let me discuss it with my consultant and I shall get back to you. So don't worry that the examiner would mark you down or not give you the mark for answering that question. At the end, if you did really well and you just apologize for not knowing the answer to this one little question, the examiner would give you a pass because you are showing good values in a doctor in terms of being honest and saying when you do not know, saying politely, I do not know about this. Also, another thing is that another scenario, a husband can come and he's very concerned about his wife or his daughter, who one of them. So his wife can be in the hospital. Let's say she was septic, collapsed, or she had a ruptured ectopic pregnancy and she collapsed, and all that you know, that his wife or daughter is in the ICU. Okay. Of course, if you know from the information, they give you that information that the wife is stable, you have all her vital signs, and you can reassure the husband that your wife is doing okay. But if you don't have that, you should not lie and just from your head say, okay, I should tell him his wife is okay. You'll be false reassuring him and lying. So what you can do is that you can say, well, Miss Smith, we are trying the best we can, hoping your wife will get better. She's in the ICU at the moment and being taken care of by doctors who are really skilled and nurses as well. We're keeping a very, very close eye on her and giving her all the medications that are needed. So this is another way that you can talk instead of just ignoring and going on to asking any question that you have. Okay, Aladdin mentioned, I'm really confused about when to explore the patient's idea, concern, and expectation. Is it in the beginning or when I start discuss her condition and management? Well, Aladdin, I know that there's like points in communication that you need to cover, but it's not always doing it directly. So you can't tell the patient. So what are your ideas, concerns, and expectations from this discussion? It sounds a little bit fake. I usually do that at the beginning. Okay, after you introduce yourself, confirm why she's here. So you can tell her, hello, Ms. Smith, I'm Dr. Aladdin, one of the doctors here. May I confirm your name and age, please? What would you like me to call you? Please call me Aladdin. So how can I help you today, Miss Smith? She'll tell you, well, I think I'm pregnant and I just knew about that and my midwife referred me here to the hospital. Okay, all right. Yes, I can see that in the letter that was sent to me. So apart from discussing your pregnancy, and I do understand that you have epilepsy, do you have any other expectations or concerns that you would like me to cover with you today? You would want to know from the beginning so you can put that at the beginning of your counseling. So that after you finish the history, you tell her, okay, Ms. Smith, let me go back and address your concerns. So you told me you're concerned about this, this, and this, and then you can address it, answer it, and then go to your management plan. Why would I recommend you address the patient's concerns right away and don't delay it? Is that since you mentioned that, it means it has marking because it's written in the role play script. If you can, even before taking history, address that concern and give her an answer, do it. But if you can't give her an answer unless you take history, then leave it until after you finish from the history. So this is what I wanted to talk about, and I really wanted to focus on it today, which is not listening to the patient, not being attentive at all. And it's a common mistake that candidates make in the exam, okay? And the fact is that they are not actually listening to the patient. Why? Because you can have, or you can already have this pre-prepared model answer, okay? And when it comes down to what the patient is telling you, you don't take it in because you'll be so fixated on, okay, I need to cover these points on epilepsy. I have practiced it with my study partner multiple times. I know it really good. Okay, I'm going to cover it. And you write down all the points in the 2 minutes that you would cover in epilepsy. And then the patient will be telling you information you're not even listening to her. All you're focused on is you want to finish all these points within the 10 minutes. Another point is that a lot of people, when they are nervous and under pressure, they will fall back into their scripts. They will just go back to what they have prepared. And another point that happens is that sometimes you don't actually give the patient enough time to express themselves. Okay, and I will focus on that. You do not give the patient enough time to express herself, and that's what I mean by ask open-ended question. Check the patient's understanding about her illness, okay, before she came in. And the other point that Aladdin mentioned, inquiring about if the patient has any concerns. Okay, so this is how, by doing these, you will let the patient express herself. And let's say you let her express herself, or she tries to force expressing herself and she does it, you can already be thinking, what will be my next question? So what I mean is that while the patient is telling you, well, I'm worried about this, or she's giving you cues, in your head you'll be thinking about, okay, if you're in the middle of history, okay, my next question would be this. You can be hearing her talking, but you don't really understand that she is trying to give you a hint to pick up something. Or you can be so fixated on, okay, my next option would be the Myrina. We're going to talk about that. And don't pay attention to her. Okay? And the problem with that is that while you are thinking of what you're going to do next, you are not listening to the patient. And that patient may be giving you a really important symptom that could be a key to the station, or a really important concern that could be a key to the station. And you are just too busy thinking about what should I ask or what should I say next. All right. An example for that is that a patient can be domestically abused. She's in front of you, but she's looking restless. Okay, she's moving around and about, left and right, sitting up and then standing up and then sitting down a little bit. And you'll be thinking, okay, I'm going to ask her about this. I'm going to talk to her about this. And then you're not looking. Okay, you can be seeing her, but you're just blinded by what's occupying your mind in the exam. And if you miss upon that, she can stop giving you cues. And then you can fail the whole station because you failed to pick that up. Okay, I know it can be difficult, but all of that will go away if you practice. And while you're practicing with your study partner, both of you and your study partner, should be trying to put in sentences in between, okay, that are not related to the medical scenario. If you're patient, so what I do for my students is that suddenly I give in the middle, when I feel okay, they're going into the flow, they're talking about this, I just ask a question out of the blue that is related to something social, and that is related to a concern I have, or something that I was thinking of, okay, as a patient. And then they would have to stop, cut their thoughts in the middle, see if they are paying attention to what I'm saying, and they would address it, okay? And then after that, they will get back to what they were talking about, pick it up from where they stopped, just to train them to get used to listening to the patient and responding and then going back on track. This is what you're supposed to do with your study partner every time that you practice. Don't do it a lot. I mean, a lot of times in the case. For one case scenario, just say one sentence. Okay. So how would you want to overcome this, not listening to the patient, and try to get used to it while you're practicing? Number one is that, and that can happen a lot during history, you may not pick up an answer that the patient mentioned that has a really, really important relation to her symptom. So number one is practice your history. You need to have a framework of questioning. And what I mean is just a framework. A framework is just like a frame for a picture. You can change the picture anytime, right? That's a framework for your history. You can change the history every time, or what we call a history template. A template is just like a template that you do for a cake, for example. You bake a cake on it, change it, bake another, like you're baking an orange cake, and then another time a carrot cake, another time a chocolate cake, for example. Every time you change the cake, this is what I mean, a template or a framework for your history. Some people say, okay, this is the history template, all right, and they apply it as it is, the same questions for each and every case scenario. It doesn't go that way. It's a framework, or called a template, because it can be changed and molded a little bit according to the specific scenario that you have. So in your head, if you know that general framework or template, obstetric history, gynae history, and then say past obstetrical, sexual, and then medical, surgical, family, you know the headings, and you know, okay, I'm going to start by this and then 2, 3, 4. You know the sequence of it, because you have to be systematic. You can and you write it down the 2 minutes while you're asking the patient questions. According to this scenario, you will automatically know what you're supposed to omit, not ask, and what you're supposed to ask about, according to it's relevant to the scenario or not. Each module has its general template or framework for history taking. So it can be on the back of your mind, and you know what you're going to ask her next. So when you know what you're going to ask her next, while she's answering you, you will be paying attention to her and not thinking about, oh my God, what am I supposed to ask her next? And also, when you know your history really well, and it's the back of your head, you just like that, you quickly ask, it will give you time to digest what the patient is saying. So you can pick up on certain cues given by the patient during history. And most of the cues, if there's something that the patient should show you, she would show you that early in the scenario or in the consultation. So you can have time to address it. So most probably at the beginning, in the introduction, she can show you a little bit of cues. Most of the time, it's during the history. Okay, so do you get what I mean? If you know your history really well, you will be asking questions. You won't be thinking, okay, after obstetrical history, I'm going to ask about medical history. You won't be doing that. You will be paying attention to the patient. So, and it's very important that also in history taking, especially social history, okay, and that you want to be like a detective when you take that. You want to explore every rock and turn it over. Okay. Okay, so enough about practicing your history. During the exam, okay, be in the moment, please. All right, I think that's the most important thing. Give your all to the patient. Say, okay, this is my patient in front of me. I'm going to focus with her. Okay, it's not about what I practiced in terms of epilepsy in pregnancy. No. Yes, this patient is epileptic and pregnant, and I already have the backbone of how should I go with maternal medicine in my head, but I will mold it and change it according to the patient, this specific patient in front of me, what she needs, what is she concerned about, what does she want to hear, okay? And in the exam, they're not going to hide things from you, okay? If there's a hidden agenda, the patient will try in every way that she can to make you pick it up. If you don't pick it up the first time, she will repeat it again. So if she asks you a question and it's the same question every time, you need to stop and say, okay, there's something there. That patient is trying to tell me something. Like I said, if a patient mentions something, it's often for a reason. She won't mention something out of the blue, not related to her medical issue specifically, without a reason. Okay, so you explore these issues. You have to really explore them. For example, I have a lovely scenario that I like. A woman who is coming with reduced fetal movement, and she's around 36 weeks. And the midwife did a CTG. CTG is okay. And you're here to discuss things with the patient. From the beginning, or let's say after you take the history for risk factors for reduced fetal movement, and then you go to the counseling. Once you start reassuring her that everything's fine and recommend that she goes home, safety net her in terms of how to count her fetal movements and when to come back to the hospital, she will tell you, well, I'm just really tired. I just want to deliver, please. Can't you deliver me? I heard that there's tablets that you can give vaginally or even orally that would really work. I had a couple of friends who had them before. One candidate can go and say, well, we don't really recommend that because you're still 36 weeks, baby's still small, and if baby's born at this time of the pregnancy, baby would need special care in the baby ICU, may have problems with feeding, and may have problems with breathing as well. And also there are risks to you as well. And then you explain to her the risks of failed induction, cesarean. That candidate can get a pass in knowledge, but they can, I think, fail safety and communication. Another candidate, okay, the patient can say, oh, well, I'm really tired. I mean, I'm 36 weeks. I just want to deliver my baby. Please, I heard there's tablets that you can give. So doctor would go like, well, yes, actually, we do have some tablets that we can give that would start off the labor as if it would be a natural labor. But would you mind me asking, why do you want to deliver this early? What made you think about this? Well, doctor, I'm just really tired. I'm exhausted, you know. I have two daughters at home and I'm taking care of them and I can't really bear this anymore. Oh, that's lovely. You have two daughters. What are their names? And then she'll tell you the names. Do you have anyone helping you at all at home? Anyone else living with you? Well, no, I'm a single mother. Okay, all right. Well, that's really brave of you. I mean, being pregnant and taking care of your two lovely daughters. Um, but it's understandable, and I can see that you're quite distressed. You're quite worried. But this is not an indication for starting off your labor. We usually have medical reasons that would make us go for such an option, and we do it for certain patients. Um, okay, so how about that? We try to look into this, okay, because I can see that your situation at home is not really comfortable, and you're really tired and exhausted. How many hours do you work? Well, I'm working two shifts, 24 hours. Who takes up the care of the girls at the evening? Well, I hire a nanny and I have to pay a lot. That's why I have to work double shifts. Okay, all right. So how about we write a letter to where you're working at and see if they can maybe reduce your workload or give you a maternity leave earlier on if that's possible. Okay, or we can arrange with social service just to see what we can do during this period. So here I picked up something hidden. Okay, I'll pass safety, I'll pass communication, because this is what the scenario is about. It's not about a first episode of reduced fetal movement. And in the UK, you don't just take care of the medical aspect. No, social aspects of patients are taken into account as well, and solutions will try to be found if they're facing any problems. I know it's a little bit difficult to do that, especially if you're starting off, but believe me, it's easy. I will admit it will take hard work, preparation, and practice. If you do that for 1 week, a whole week, you're just focusing on your communication, how to respond back, you will be really good at it. It won't be a problem for you at all. So once you've sat down and practiced with your partner a certain case, and you find out that there are certain times you hesitate in answering, or you're not entirely sure what to mention next, it's better that you do it now with your mates, okay, in a group. Even though it can be a bit embarrassing, especially if there's lots of people listening to you, but it's very, way much better than doing it in the exam. Okay, I have a question here. I did as well. When patient is giving cues or hint about, for example, domestic violence, at what point I should raise and assure her about confidentiality? I mean, how will I make her trust me and talk? Okay, so sometimes, okay, let's say she gives you a hint about domestic violence, and she tells you, well, I'm in a hurry, I need to really go back home. And you ask her, why are you in a hurry? You don't ignore it. Well, I have to go back. My husband, I didn't know that I came. Why didn't, remind me asking, why didn't you tell your husband? I mean, you came in here for a reason. Okay, how about you call him and tell him that you may be late a little bit? No, 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 I can't. Why? What's going to happen? Well, he'll get angry. But just never mind. Just let's just finish quickly. So she'll try to close off the subject at some point. At that point, you can, because you want her to open up, you were assure confidential. Tell her, Louise, I'm just quite worried about you. I can see that there's something not okay, and you're not comfortable. I would assure you that everything that would be mentioned here or discussed would be confidential between me and you, unless I do have a safety concern that I may need to involve other people as well. So because you know, if there's a child involved, you would need to involve child protection, even if the child hasn't been hurt. As long as there's a child witnessing all of that, child protection needs to be involved. So you have to be really honest that you may breach it. Don't lie to her and tell her this is going to be confidential, and then later on tell her, well, sorry, I have to go and tell child protection or social services. Okay. Let's say you find that out during examination. They give you findings and you find bruises, marks all over her body. Here you can start with confidentials right away. Tell her that, Louise, when I examined you, I found bruises on your back, your tummy, and your thighs. Can you tell me where you got these from? Well, I just fell off the stairs a couple of times. Okay, all right, but I don't think that these bruises match with a fall. Okay. I'm just quite concerned about you. And here in the hospital, we usually want to pick up anything that's concerning and try to help our patients as much as we can. I assure you everything would be kept confidential between me and you unless there's a safety concern. I would need to involve other people as well. So can you tell me what happened? Has your husband or did your husband do that to you? So direct questioning about abuse is very important. Don't go around in circles a lot. Okay. Don't try tell her, okay, what happened? What happened? And then again, what happened? No. If it doesn't open up to you about it from the first time, you would directly ask her, has your husband hit you? Did your husband or did your boyfriend do that to you? Okay. Anyone has any question? Okay, there's a few questions here. Okay, most welcome, Aladdin. Okay, Samia asked, what's your YouTube channel? Just write on YouTube, MRCOG Part 3 Circle, and then you'll find around 8 videos. Okay, Facebook as well, MRCOG Part 3 Circle. There's a page and there's a group. You'll find the post there on the group, and the same is for the Telegram. If you want, I wish if I could send the link of the Telegram here, but it will only be a message, and it's like you need to decode it, something like coded. You can find the link there on the Facebook group. Okay, I have put it there. Okay. Megha, can we get recording of this session? I missed it. Yes. Okay. I'll either post it on. Okay, I'll post it on the group, Telegram group, or it would be uploaded on the YouTube channel. I'll just let you know when and where the recording is posted after it's posted. Okay, Dina asked. Okay, yes, Dina. Actually, it's written on the website that I have a communication skills workshop, but it's I haven't really finished preparing for it yet. So it's not. I'm just sorry. I apologize. It's not open at the moment. Yeah, you did try to click on it, but it didn't give you a page. It's just because it's not an error, but it's not ready. Okay. At the moment, I just have the video circuit one, virtual one, and the regular 7-week course that I have. Only these two, but the communication skills, no, it's not yet on. Asking if the patient asks, how much time do I have to live after breaking bad news in cancer station? What should we say? All right, she gave you a concern, so inquire the reason behind her consent. So the first thing you would tell her, so you would ask her that, why are you thinking that way? Is there something concerning you, or are you thinking about something particular? Well, I have heard that usually patients with cancer do die. Well, Suzanne, it doesn't happen all the time, okay? We still have lots of information to know about if your cancer has spread or not, and if it has spread, to which areas it has spread, all right? And also, it would depend upon the treatment. So, science has advanced a lot, and we have lots of treatment modalities. For the time being, I wouldn't want you to be concerned about this, okay? And if anything can be done, rest reassured that we would be helping you throughout. So you're just trying to be honest because you can't tell her, no, 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 you're not going to die. You'll be lying. Okay, after the test results, the the MDT recommendation comes back, they can tell she has a stage 4, she's just for palliative treatment. So what, you just falsely reassured her right now that she's going to get shocked. So you just be honest and just say an answer similar to what I mentioned. Aladdin, how to bring the patient back to the point of consultation if she starts to talk about something else not relevant to her problem. Well, I don't understand in some exams, but it didn't happen in the RCOG before. She can be talking a lot about something, and she can be telling you a story about her neighbor, story about her dog, a story about what happened to her yesterday when she went grocery shopping or something. If she does that, and she'll be instructed to do that, she's not sharing with you any concerns, she's just telling you stories about her life, then you tell her, Suzanne, well, I'm really enjoying chatting with you and your stories, but how about we finish from the consultation first, and then after that we'll have time to chat. What do you think? Then you go on to the consultation. So they want to see if you're going to be polite or not. So you have to be firm and polite at the same time. And around to ask, if you miss 1 or 2 of the asterisk points, will they fail? So not all scenarios have asterisk points. Those scenarios which have asterisk points, let's say safety in ectopic pregnancy has an asterisk point, and there are 2 points that have these asterisk marks. If you fail to mention one of these out of the 2, you will fail patient safety, and usually it will be something major. Like, for example, let me give you an example for an ectopic. She is not suitable for expected management, and you give her that option. You didn't exclude expected management. They will fail you right away, because you just jeopardize the patient's life. Or if she has a contraindication for the methotrexate and you offered it to her, I think that's another asterisk point as well. The other way around, if you mention only one of the asterisk points out of all the other points under safety, you will pass. Okay, you'll pass the whole domain. Okay, any other questions? Someone has clicked the hand. Let me see the hand, see if someone wants me to mute. Humaira, did you click the hand? Well, I muted you if you wanted to ask a question. No, so I guess that was by mistake then. Okay, Preeti? Preeti, I unmuted you. You just need to unmute yourself.
Hello. Hi, Dr. Wafa.
Hi, how are you?
I'm good. Thank you. How are you?
I'm fine.
So, Dr. Wafa, my question is that this time the exam is virtual. So, in the teaching scenarios, there would be limited scenarios like reflective practice, audit. So, what do you think would be very important in the teaching? I don't think that they will give the instruments or pelvis reading. It's not possible in virtual, isn't it?
Yes, the exam is going to be virtual friendly, meaning it's suitable for it. So yes, hands-on teaching will not be there. It can either be bullying and undermining, teaching something theoretical,
Yeah.
like for example, yeah, teaching them about preeclampsia, ectopic pregnancy, or how to conduct an audit, okay, basic topics, how to go through a maternity dashboard, and it can also be giving feedback to a form they have filled, or reflective practice after they have mismanaged a case, for example.
Yeah. Yeah. I was
But
thinking in the same
nevertheless,
way.
yeah, when you are asked to teach something theoretical, like for example, they wanted to know about preeclampsia, and you had a case scenario in the ward, and they bring it to you, you apply the same principles of teaching. just exact the same to something theoretical.
Okay. Okay. Yeah, I got it.
Okay.
Thank you so much.
All right. You're welcome. Okay, Fatma said, what about answering the patient, am I going to die again, please? Okay, my answer this time may be a little bit different because I just pop it out from my head suddenly. So the first thing you'll do is ask her. Let's say her name is Amy. She said, Amy, sorry, she said, doctor, am I going to die? Well, Amy, it's understandable where this is coming from. I mean, everyone who has cancer would think about death. But may I ask you, are you concerned about something? Well, I just heard that everyone who has cancer, they ultimately die. Well, to be honest with you, we don't really think about death when we diagnose someone, a patient with a cancer. We usually take things step by step, and we need to know more information about the stage of your cancer that has spread and how far is it has spread. Also, it would depend upon the type of the treatment that you would receive. And science has really advanced a lot, and we have lots of treatment options for cancer that weren't there before in the past. So for the time being, I just don't want you to worry about this. I understand it can be a little bit difficult for you not to think about it, but we will be trying our best to help you, okay, in the ultimate way that we could. So let me ask, how can we draw and show the patient? Well, if it's digital, no, you wouldn't draw in the exam, okay? Okay, any questions? I don't see any more question. All right, I was just planning for this to be 30 minutes, but like usual, my classes usual webinars extend double the time. So we've been doing this for an hour now. If you have any questions related to this, just send it to me on the Telegram group. Okay. All right, everyone. Good night. I hope you enjoyed it and see you next time. Bye-bye.